So we have all these diseases, right? Obesity, type 2 diabetes, strokes, cancers, dementia. So if I were to ask you, what is the proximate cause? Like we are always looking for a primary cause or a causal factor, one factor that is leading to all these modern diseases.
Inflammation.
Insulin.
So somebody says inflammation.
Insulin.
Insulin, what do you mean by insulin?
Insulin resistance.
So insulin resistance is one of the factors, okay? Inflammation is another. So keep that at the back of your mind, like you have two answers. At the end of the talk, you're going to tell me which one you're going to select. So in order to explain this better, as to why we are getting all these diseases, we have to look into what we eat. So would you be surprised that about 60% of American diet comes from only 3 nutrients: grains, added sugars, and vegetable oils. So this trifecta, 60%, accounts for some of the many factors that we are going to see, whereas consumption of animal food, animal protein has gone down, consumption of animal fat has gone down. But if I were to ask you between 1960 and 2024, have those diseases gone up, stabilized, or gone down? They have gone up, okay? So there could be an association. So when you take sugar, and I don't think any of the donut shops actually use any of the animal fat because vegetable fat is so cheap. They take grain and they take Crisco. Crisco is crystallized vegetable oil. What do you get with that?
Donuts.
You get a donut. And if you look at the number of calories that we are eating over time, like this is 1961, we used to eat about roughly 2,800 calories. Now we eat about 3,700 calories, so we are eating more. Calories that we eat from grains have gone up. Calories that we get from vegetable oil has been the one that has increased the most. Why is vegetable oil consumption very high in the United States or all throughout the world? Number one, it's cheap.
Yeah.
Number two, you cannot make it bad. You cannot make vegetable oil go rancid. You can make other fat go rancid. But what's the most important aspect as to why it is going up high is because mainstream medicine, including American Heart Association, talks about it as healthy fat to consume. So that is a shocking thing for me.
There's a decent amount of us who used to remember Mazola margarine.
Oh my God.
Okay, a little corn thing on there. Oh yeah, that looks great. This crap.
Mazola margarine.
Margarine, yeah.
Margarine, yeah.
Okay. So the weight of Americans has gone up. We used to be about 170 pounds for men in 1960. And we are about 208 pounds or a little over 200 pounds in 2010. So who do you think is at the bottom out there, the dashing, slim-looking young man? I mean, all of you guys should recognize him.
Clark Gable.
That's Clark Gable, right?
Oh, yeah.
So do we look at like Clark Gable these days or Danny DeVito?
Yeah. Yeah. We love Danny though, come on.
Why, you love him, that's for sure. Because he's a good humorist.
That's he is.
All right, along with our obesity, our waist circumference has gone up too. So our abdominal obesity in the 1960s was about 83 centimeters. It's gone to 94 in men. But look at the change in women. A whopping 18 centimeter increase from 60s to now. So why did we get heavier and sicker? You said inflammation, somebody said insulin resistance, so let's look into that. So this gentleman is an icon. He is a messiah, somebody who kind of taught us a lot. His name is Joseph Kraft. We talked about him about 4 or 5 years ago, then we stopped talking about him. But we are going back and doing kind of a refresher course, so we should talk about Dr. Kraft. So he was a World War II vet. He did a very important assay, which was called a radioimmunoassay for insulin measurement. So before his time, insulin could not be measured. You could measure blood sugar, but you could not measure insulin. So I have never gone through a glucose tolerance test, but has anybody gone through a glucose? So some of you have. So you drink about 75 to 100 grams of glucose, and then at half an hour, 1 hour, 2 hours, 3 hours, 4 hours, 5 hours, and 6 hours, you get your sugar taken out. The abbreviated version of it lasts only 2 hours. So you may have had a 2-hour glucose tolerance test. So Dr. Joseph Kraft, he was a pathologist somewhere in a Chicago hospital, and he was one of the pioneers of the glucose tolerance test. And this is how glucose tolerance test is described to you. If you take the glucose load and you measure your blood sugar in this time frame from 30 minutes to 6 hours, and your glucose remains below 140, you're considered to be normal. If it's between 140 and 199, you're pre-diabetic. If it's above 200, then you're considered to be a diabetic. Dr. Kraft did 15,000, 14,500, so I'm kind of rounding it up to 15,000 of these tests in his career. And of that, he said 9,500 came out as having normal blood sugars in that 6-hour period. About 2,700 were pre-diabetic, and a little over 2,000 were diabetic in this 15,000 patients he studied in his career. But he just didn't do a glucose tolerance test. He also measured insulin levels. So along with glucose at 30 minutes, 1 hour, 2 hours, 3 hours, 4 hours, 5 hours, and 6 hours, he checked insulin levels too. And he said, based on his clinical experience and looking at all these 15,000 studies, normal insulin response, if you take a normal person who's metabolically healthy, this is where the insulin should increase. So it's kind of low, about 5 when you're fasting. At a half an hour, it should jump between 50 and 60. At 1 hour, it's close to 60. Then at 2, 3, 4, and 5 hours, over time, it's coming back to baseline. It's coming back to about 5. Go ahead.
What are the units on that?
So it is micro MU per ml. Okay. I think the next slide will show you that. So now we are talking about the 9,500 patients that had normal glucose levels. In other words, these patients would not have been classified as being diabetic. So these people would go walk around and say, I'm not a diabetic, and he wanted to investigate these people. Of these, based on his evaluation, he found that nearly 75% of them, 7,500, despite having high sugar levels, had high insulin levels. Okay? So this slide is important, and we'll go through that in detail, and I'm going to kind of try to use my cursor. So this blue is the normal insulin response, as you have seen. You know, insulin is going up to about 60 at about an hour, and then gradually coming back to about 5 at 5 hours. This other line is the group that would be called as pattern 2. Pattern 1 is normal. Pattern 2 people, when they get the glucose load, their insulin is going to go above 100. It's slightly delayed. The peak is slightly delayed compared to normal, and then it gradually tries to come back towards normal but doesn't completely achieve it. Type 3 is in this amber line. One of the striking factors of this is that the rise in insulin is delayed. It doesn't go up immediately. There is a slow rise, but it goes up to about 150. And then it gradually comes down but remains higher than what it started out, higher than baseline even at 5 hours. The pattern 4, now these people are people who are making a lot of insulin. So if you see people in your immediate circle who are morbidly obese, who are like 350, 400 pounds, or shorter and heavier, have a BMI greater than 40, these are people who are designed by nature to have a pancreas that's making insulin that undergoes what is called islet cell hypertrophy. The islet cells increase in size, and so they're making a lot more insulin. So their insulin is higher to begin with, and it can go up to about 200 and never come down to baseline. But even in this group, look how delayed that insulin increases. In other words, it doesn't go sharply up, it goes gradually up. Okay? So I divided them as, according to insulin, these people are morbid obesity, then there is obese, then there's overweight, and usually people with normal insulin levels are normal weight, but there can be some healthy obese that we may or may not be able to get into. So among the 9,500 patients he studied, only 2,000 were normal insulin, whereas pattern 2, which is overweight, pattern 3, which is obese, and pattern 4, which is morbidly obese, constituted about 7,500 of these 9,000 patients. So it's estimated that if you take a general US population, about 70% of us are insulin resistant. Even though we may not be a diabetic, insulin resistance meaning that they're making more insulin than normal in response to food intake. And the reason this is important for us, so here is a 24-hour insulin profile in an obese person, and you can see, and again I'll use my cursor, the insulin levels throughout the day are high. With each meal they get higher, and even with this mid-afternoon snack and with dinner it remains high, and it doesn't ever come down to normal. Now this one is in picomoles, so that's a little different from MU per ml, so the units are different, but suffice it to say that the insulin levels remain high in people who are insulin resistant. So we looked at this trifecta, which is basically grains and added sugar, and we can safely say that we are a nation of carboholics. We eat a lot of carbs. And when we eat a lot of carbs, you get toxic hunger. Toxic hunger means that as you're eating these carbs, the insulin goes up. Now, some of that insulin is used to convert sugar to usable energy, and sugar can be then converted to glycogen that is stored in our body, but we have limited ability to store glycogen. The rest of the carbs that you eat gets converted to fat and gets packed into the fat cells. So as fat cells increase in size, they release a hormone which is called leptin. Leptin goes and tells the brain that you have too much energy reserve, stop eating. Okay? So it should tell you to stop eating. However, when your insulin levels are high, it creates what is called leptin resistance. High insulin levels prevent the brain from seeing leptin. So leptin is no longer signaling, and one of the reasons people who are on a carb-heavy diet keep eating is because of this toxic hunger from insulin resistance. So one of the best ways to improve your health is to become insulin sensitive, to reduce the levels of insulin. Because not only is insulin responsible for hunger, but it also is responsible for high blood pressure. It also reduces your good cholesterol. It also causes obesity, because when your insulin levels are high, can you burn fat? No, because fat is locked down. High insulin levels prevent your body from burning fat. Fat is not available as an energy source. It's responsible for strokes, for heart disease, High insulin people usually have markers of inflammation. High insulin causes cancers, and I'll tell you the biochemical steps that it causes it through. High insulin level also causes type 2 diabetes, and I'll go through that in detail, and as well as dementia. So the question we should ask ourselves is insulin always a bad player, or is hyperinsulinemia different than normal insulin action?
Yes.
So it is. So let's what does insulin do in our body? So here is an insulin receptor. Insulin comes and binds to it. And once it binds to it, there are some signals that the cell does inside the cell through which it mobilizes a pore through which glucose is then taken into the cell. The glucose that is taken in can either be used for energy, so it's burnt in the mitochondria, or if there is excess glucose, it can be stored as glycogen. If there is way excess glucose, then you're going to turn it into fat. But not only does it mobilize sugar, it also mobilizes certain other factors out here. So these are the other intracellular signaling pathways through which it makes new protein. So in other words, you exercise, you are metabolically healthy, you can use your insulin to make new protein because that insulin spike gives signals to the body to make new protein. On the other hand, if insulin is being activated all the time with hyperinsulinemia, it's not just protein synthesis, but it promotes cancer biology. In other words, it makes cells grow. So Pam asked me about polyps. How could you prevent polyps? The way you could prevent polyps is by being insulin sensitive. Now, most people think that insulin only regulates carbohydrate metabolism. But we would be wrong. Insulin is intimately involved in regulating fat metabolism. So when we eat fat, right? And when we eat carbs versus and protein, does the body deal differently with fat versus carbs and proteins? In other words, if I were to tell you from the gut, from the small intestines, carbs and protein are going directly to the liver. Okay? Where does fat go? I want you to think about it. Does it go to the liver or does it bypass the liver?
It goes to the liver.
So it bypasses the liver. What happens is that the fat is put into these fat globules called chylomicrons. So there is a protein cover and there is this fat globule which is called a chylomicron. And the chylomicron gets dumped directly into the bloodstream. So from the intestines, it's going through the lymphatics, through the thoracic duct into the bloodstream. And this fat-filled globule is in search of two things. It's in search of a fat cell to dump its fat cargo. So in order to dump the fat cargo effectively, it needs insulin because insulin activates an enzyme called LPL that makes it dump the fat cargo. It can also dump the fat cargo into the muscles like the skeletal muscle and the heart to be used as energy, or a small amount of it can be stored in there. Now, is insulin important for your brain? Let me ask this to you guys. Let's say you had a bad night of sleep, didn't sleep well. You're groggy, maybe you have something important to do the next day. What would you do in order to feel better? So if I were to tell you that you didn't sleep well results in what is called insulin resistance, which means insulin doesn't work well. So we know that insulin is required to push glucose into the cells. So when a brain is insulin resistant, can it use glucose? It cannot. Okay? So you feel groggy. What would you do? Let's say there is a student, he's pulled in an all-nighter, didn't sleep well, has an exam to do the next day. What does he do?
Drink coffee.
drinks coffee. Okay? And then also, what is in the coffee? Lots of sugar. They'll have maybe a muffin with it or some confectionery like some kind of a sugary cake. Because when you drive your insulin levels up and you drive your sugar levels up, you can force the sugar into the brain and the brain can think well. So thinking and cognition requires use of fuel by the brain because insulin receptor activates the pore through which you take in glucose, and there are intercellular signaling in the brain that give you cognition and memory abilities. So insulin is important for the brain. So to summarize, insulin makes you store sugar as glycogen in the liver. It can cause protein synthesis to make new muscles. It puts fat into our fat cells, and if the fat is in your fat cells, it protects your heart, it protects your liver, it protects your pancreas, and it helps the brain think better. Now this is an old slide, but I wanted to put it up there because what releases insulin the most is a combination of glucose and protein. So when you take glucose and protein, so here is 50 grams of glucose and 50 grams of protein, the spike in insulin is the most. The spike in insulin is there with glucose alone. It also goes up with protein, but see that the rise is a little slower and the peak is more delayed. Okay? Fat does not increase, insulin increase. So this is somebody taking a bunch of butter as the only fuel. Do you see a rise in insulin levels there? No. Okay, good. So this is what I think is eating properly. Many of you think that, many of the mainstream people think that this is not because they think whole food, plant-based diet is the right way to go. And when you're eating like this, you are insulin sensitive. That means insulin is working well, just like I told you before. It's making sugar enter the cell. It's making new protein. But in the setting of insulin resistance, there's a lot of insulin. The pancreas is pouring out insulin, and when that happens, the receptor doesn't function well. The receptor, first of all, the intracellular signaling is not there. So in other words, it's not activating the GLUT4 pores, so you have high sugar in your bloodstream, but the cell is starved of energy. The cell cannot use energy. Another thing that happens is what is called receptor downregulation. I have used this story many times. You see an opioid addict, right? They get the first dose of opioid. Do they get a massive pain and pleasure response?
No.
They do.
Oh, okay.
The first time they take opioid, they get a massive pleasure and pain control response. But as they keep taking it, does the response remain the same?
No.
Or does it go down?
Goes down.
So in other words, there is tolerance. You reduce the response. So these people have to take higher and higher doses of opioids to get the same degree of response. And sometimes they cannot figure out how much to take, and that's why they overdose. The reason for that is that our biology is one of what is called agonist-mediated receptor downregulation. It's a mouthful, but what that means is that as the insulin binds to the insulin receptor, the receptor goes into hiding. It goes inside the cell, and it's no longer present for insulin to work. And sometimes, if insulin resistance is to excess, it fuses with the garbage disposal mechanism in the cell, which is called lysosome, and the insulin receptor, instead of being recycled, is completely destroyed. It can happen in the brain also, high insulin levels over a long period of time. So type 3 diabetes is brain insulin resistance, in which the brain cannot use fuel. You have a lot of sugar, but there is no insulin action to get the sugar into the brain cell, and that is the reason why you cannot think, and you cannot create new memories. I want to take you through this basic thing, which is the human pancreas. So this is the human pancreas, and in red out there are the insulin producing beta cells. And in close proximity to those red cells are the green cells, which are making glucagon. And so this juxtapositioning, in other words, the closeness of these two cells, is that an accident of nature, or is there a real purpose to that? That's the question I want to explore. So this is a normal pancreas. This pancreas doesn't have any red. That means that the insulin making machinery is destroyed. This is a type 1 diabetic. On here is an early type 2 diabetic. So if I were to ask you guys, if you see an early type 2 diabetic, are they heavier or are they thinner? They're heavier. The reason they're heavier is because they're making a lot of insulin. When you make a lot of insulin, you store fat. So this is the question that goes down to explaining what you were asking about. When the pancreas sees sugar, a normal pancreas sees sugar, it has a rapid squirt of insulin. It squirts insulin very rapidly. The reason it does that is because it has pre-prepared insulin granules inside it. So it's ready. As soon as it sees sugar, it's going to put that insulin into the circulation. And this phase 1 insulin response is very important, and I will show you why. And after that, there is a phase 2 response. One of the first things you lose when you become insulin resistant or hyperinsulinemia is that phase 1 response is gone, because the pancreatic cells are constantly pouring out insulin. They don't have any reserve left in them to create that phase 1 response. What happens in people who are on a chronic low carb diet, like for example, somebody is just completely low carb, doesn't eat any carbs, the body says, I'm making all these granules, insulin granules that are not being used. Why should I make them? So it stops making them. So that is one of the reasons for the phenomena of what is called as insulin resistance with a low carb diet. I told you that the insulin making machinery and the glucagon making machinery is right close to each other, because the reason for that is that as soon as insulin is made, the highest concentration of insulin is right at the level of the alpha cells, which is making glucagon. So when insulin is made, the alpha cells see the insulin and they shut down glucagon production. That's an important thing. The next important action of insulin is at the level of the liver. So the pancreas is dumping insulin into the liver, and it is important for the liver to see that insulin. So let's kind of try to figure out why. Okay? So I'm going to pose a hypothetical question to you. If you eat a lot of food, and the food will have protein, will have some carbs, should the liver shut down production of glucose?
From carbs?
Yes, right?
Should the liver...
Okay, that's me talking, huh? So when you are not eating, the liver is continually putting out some sugar for the brain to use, right? And it is doing that through the action of glucagon. So when you eat a large meal, the liver should see the insulin first so that it will shut down glucagon, should shut down glucose production. And then the rest of the body, the fat and the muscles, see a much lower level of insulin. So the dilution from here, from the level of the pancreas to is about 5-fold, and the dilution from there into the bloodstream is 20-fold. So a lot of reduction. Can people who take insulin from the outside match that? No, because the insulin that you're taking from the outside is the highest concentration is in the bloodstream. It never reaches the normal concentration of insulin being released from your pancreas itself. So that's one of the most important aspects for you to recognize to protect your pancreas. So here it is showing you in detail. This is the phase 1 insulin spike when glucose is seen as the sugar levels increase. As soon as the spike is there, the spike is seen by the alpha cells, glucagon level is shut down, and it remains down in the duration for several minutes to hours after the insulin is released. This is a type 2 diabetic. In a type 2 diabetic, this is the insulin curve. Do you see a phase 1 response there? You don't see it at all. Okay? There is no phase 1 increase in insulin. Insulin is growing up gradually with a carbohydrate meal, but it's peaking very late at about 45 minutes. So the pancreatic cells that are making glucagon don't see that insulin, and glucagon level remains high. So you have eaten a lot of food, there's a lot of sugar coming into your bloodstream, but in a type 2 diabetic, they are getting signals to the liver that make more sugar. Do you see what I mean? So that is something that we need to kind of put in our mind, because insulin can store sugar and use sugar, it can build new protein, it can pack fat and store fat in the fat cells, whereas glucagon makes the liver release sugar, it breaks down protein to make sugar, and it breaks down fat to make sugar. So when you have eaten food, you want glucagon to shut down. Because when glucagon is not shut down, there is this protein breakdown with gluconeogenesis, with glucose output. There is breakdown of your fat cells so that you can make some glucose, but the liver cannot burn that fat and convert it into ketones because you have high insulin levels. So what's the liver going to do? It's going to take that fat and put that fat out as triglycerides. And those triglycerides are going to get into your blood cells, going to get into your pancreas and cause disease. So Lydia Shishipang did this study in which she looked at the amount of pancreatic fat content. And she found that normal people had less pancreatic fat content. People who had normal glucose but were obese had slightly higher. When they had impaired glucose tolerance, the pancreatic fat was high, and it was the highest in people who were type 2 diabetic. So I have gone through this already, but basically what I'm trying to tell you is this vicious cycle of increased insulin levels, increased glucagon with repeated feeding in type 2 diabetic is something that the medical profession doesn't recognize. And what happens is that type 2 diabetics are still being asked to take a carbohydrate-rich diet. This is juxtaposing the two. We are juxtaposing insulin and glucagon in a normal situation out here. This is the normal pancreas. This is insulin and glucagon and glucose in a type 2 diabetic. Okay, so I think what I'll do is that I'll break this presentation down into two parts. So first part today, I'll finish in about another 5 minutes. And the second part, because I think it's going well, but if I rush through it, it will not have the same impact. So if I were to ask you, what is the primary function of fat cells? What would you say?
Store energy.
So somebody says store energy. But if I tell you that they have an even more important function, what would that be?
To accommodate that?
Go ahead.
Protect the heart and the other organs.
So one of the most important aspects of the fat cells is to protect the heart, the liver, and the pancreas from fat deposition. So there are some individuals who are lucky. So in other words, when you have fat cells, the fat cells can increase up to 20-fold to accommodate fat. After they go up 20-fold, they say no more. I can't take fat anymore because it requires so much insulin to pack fat into them. And that high level of insulin and hypertrophy, what happens is that these fat cells ultimately give up and start dying. And you get inflammation in the fat cells that you can measure as low adiponectin level. It's a fat hormone that is elaborated when fat cells are healthy. On the other hand, unlike men in whom they usually have fat cell hypertrophy or fat cell enlargement, women are somewhat lucky, at least until menopause. In women, the fat cells, instead of enlarging, they divide into multiple baby fat cells that don't become unhealthy. So I'd find several women who come to my office who are somewhat heavy, BMI 30, 32, but they have high levels of adiponectin. These are people in whom the fat cells will protect their heart, they'll protect their pancreas, protect their liver, and they never become insulin resistant. So what healthy fat tissue is tissue in which after you eat, the fat can be rapidly packed into the fat cells. The fat tissue releases the right amount of fatty acids for energy, doesn't release too much, because if you release too much, the liver cannot cope with it. It'll put out more fat that will get into your heart and into your pancreas. So the liver can take the right amount of fat that it is releasing, convert it into ketones for brain to use, go to the muscle can use fat for energy, and the heart can use fat for energy also. Unhealthy adipose tissue is fat cells that have expanded and they say no more. We can't take fat anymore, they become unhealthy, they die, they have inflammation. And when they are big and overstuffed, what are they doing? They are spewing fatty acids into the bloodstream. And when they spew fatty acid into the bloodstream, there's a lot of fat that is then picked up by the liver becomes fatty. But these people are insulin resistant, so they cannot make ketones, so they cannot fuel the brain. There is fat in the muscles, there is fat in the heart, there's supposed to be a pancreas out here, there's fat in the pancreas too, causing fatty pancreas, which is now considered to be what is called visceral obesity. So I will stop here, and next time when we come, we can talk more about how to extend this paradigm more, and how there are studies that show that low carbohydrate diets will actually help reverse insulin resistance, reverse diabetes, help you lose weight, help you improve your blood pressure. So there are a number of studies that we can talk about. So I will stop here and open it up to questions from you guys. But thank you for coming. We will continue this in August.